It's live right now. So this is the wrap up. It's not super fast, but it is working. So the audience will have live participation, and then we have this, the suggested ones, but everyone will input. Yep. So sure, don't go too far. We're gonna take a picture. Can we take a picture, please? No, you do.
In here, we can't change because one
Are we testing this microphone? Yeah, it's working. Fantastic. Okay, we are on time, so we start now because we have to move on. Welcome, everybody, to this patient-led session. And first of all, welcome to the Gcom for all the patients, all the caregivers, and the healthcare professionals, and everybody who is joining us today. You have probably seen in the program that we are going to have 5 different patient-led sessions. I move on. And we start today with this session about holistic approach for myositis patients. So you will see we are going to take a little Mentimeter poll, and we want to know about your expectations for this session, and what we are curious to know what you are going to expect from this Gcom this year. My name is Anneli Dikan, and I am from Sweden, and with me I have Paula, and she will go on here.
Thank you, Annalie. And don't go far. I join Annalie in welcoming you all to Gcom and to the first of our sessions and workshops in the patient-led track, open to all, but specially designed to help those of us navigating myositis journeys flourish in those journeys. So we are, many of us are here physically in Lisbon, but we also have a number of colleagues who are connected remotely via the virtual link. And so our colleague Linda Kober is monitoring that, and we invite our virtual colleagues to complete our introductions as well. So we're interested in knowing from our online attendees name, country, patient advocacy organization, if applicable, and a myositis diagnosis. And for everyone in person and online, please join us in our poll question. You can scan, oh, look at that, Annalie. They all got it. Good. Phones up. Cameras scanning. Tell us what you are hoping to get out of Gcom 2026. And we should see the results refresh slowly as folks come in. And I know one thing that I'm hoping to get out of Gcom, Annalie, is a little more understanding of artificial intelligence. At one of the patient-led workshops tomorrow, we have experts sharing about artificial intelligence in myositis, which I think will be very interesting. Okay, I am trying to refresh the Menti poll, so keep putting your responses in there. Oh, wow. You guys are gonna like it when it refreshes. I have a sneak preview here. Look at that. Ooh, and it's moving around. I just love it when technology works. Special thanks to all the really gifted technology experts in the back of the room, and with us, thanks to EEM as well, the meeting organizer for iMyos and Gcom. Okay, looks like most people have updated or entered their responses, so we see a lot of alignment around hoping for knowledge, networking, and connection here at Gcom. I think that's probably a pretty representative response, Annalie. So thank you all and welcome everyone. Now, just so we can get to know the in-person audience a little bit better, we don't have time for every single person to introduce themselves, sadly. Find me at the welcome reception later, though, because I'd love to know everything about each one of you. In the meantime, let's just do maybe a quick show of hands. Any other Swedes here, Annalie? Oh, okay, yep. I know I have some Americans here as well. Yes, show of hands. Okay, great. Let's see, I see a Swiss friend. Yes. Oh, who else? Oh, Turkey? Yes, okay. Kind of, yeah. I would also like to be kind of from Turkey. What a beautiful country. Okay, any other countries represented? Would anyone like to share anything quickly aloud? Yes. Oh, yes. The Netherlands. The Netherlands. Marie-Christine. Czech Republic. Belgium. Portugal. Well, our beautiful host country. Thank you for your gracious hospitality. Okay, terrific. Well, we will move on into the educational content of our workshop, but we have another super fun polling question at the end, so don't worry, there is going to be a lot of interactivity in today's workshop about living holistically with myositis, balancing conventional drug therapies with functional medicine and lifestyle changes. And I know that we're all here in Auditorium 8 and online because we know that the value of patients attending and contributing to the program in Gcom has been recognized ever since its inception in 2015. With subsequent Gcoms over the year, there has been increasing interest and participation by patients, care partners, and the organizations like TMA that represent them. And so here at Gcom 2026, patient voices will be echoed throughout the daily program with patient perspectives shared in the scientific sessions. And here, patient-led workshops and sessions, as Annalie alluded to. In total, we are offering more than 550 minutes of dedicated airtime from patients and for patients, and this emphasis ensures that all participants, 650 plus, here in Lisbon, plus those online, will benefit from the vital perspectives of the individuals with lived experience in the forms of myositis. So again, welcome, and welcome to our experts and the clinical support faculty for this session in particular. Annalie and I have no disclosures. We do have some housekeeping requests. This is not one of the really fun interactive elements I promised you, but as a reminder, silence your phone. You definitely are welcome to take pictures. In fact, we'll be taking hopefully a group photo afterwards and a photo during our demonstration. Keep chatting online, and Linda will keep relaying that to us. And here is our agenda for the next hour and a half or so with the times breakdown. So it's going to be an action-packed 90 minutes, and we can leave the slide up just another couple of seconds. Folks are taking pictures of it. That's good. And now Annalie will conclude the introductions, and then we'll introduce our first speaker. Annalie, comments?
Thank you. You might notice that I have also given you all the little bit of paper that you have all the text for these slides, because we think we are going to get them a little bit hurry here, so we have to move on very fast. You will. I have this little quoting from our former patient who is now cured, Lars Nordell in Sweden, who is a psychotherapist, and he's giving really nice words about how do you move holistic about the thinking. And this picture we have also, who we kindly got from Leslie and Sakatu from the Myra. You can study the picture because it is so many things in it, so we don't have really time to talk about it thoroughly, but you can study it by yourselves. And now we are going back to Paula and our first expert, who is going to give us a lecture. Please, Paula.
Thank you, Annalie. Excellent context on what is meant by the holistic approach. And we really do want to include every aspect of being a human and being affected by myositis in today's session. All of our presenters are open to questions, so submit questions at any time, and presenters will answer them at the conclusion of their presentation. So for the first part of our workshop, we will have an overview of functional and lifestyle medicine from Dr. Shur Balichalar. Dr. B is professor of neurology and co-director of the neurology residency program at McGovern Medical School, University of Texas Health. She is board certified in neurology and neuromuscular medicine, and she specializes in nerve and muscle pathology. Her clinical and research interests include muscular dystrophies and the IIMs and advancing care for neuromuscular disorders. We are very pleased to welcome Shur, and we know we will enjoy learning about lifestyle medicine and its 6 pillars. Please.
Thank you for having me. It's a pleasure and a privilege to be on this podium. So I practice in Houston, Texas, in the U.S. So our healthcare system is a little bit different from a lot of the other European countries, or a lot of European countries. We have mostly private insurance, and then for our patients who are over 65, we have Medicare, and then for patients who are younger than 65 and who cannot afford, we have Medicaid. But unfortunately, our healthcare system needs a lot of improvement. And our patients and us as physicians and other healthcare providers, we're sort of stuck. And what happens during our interaction with our patients? We're almost in a rush. We have maybe 10, 15 minutes or sometimes 20 minutes or so to go over everything and to be able to come up with useful recommendations for our patients and also advocate for them. And in the end, I think there's a lot of frustration because we're able to talk about medical treatments, but we're not able to really approach our patients from every other angle, such as nutrition, exercise, because we know that those are really important in making sure or optimizing our patients' well-being and also response to treatment. Therefore, American Academy, actually, now they have an American Academy of Lifestyle Medicine. And you can be a physician, you can be a physiotherapist, you can be a social worker. There are different tracks that you can actually take, and you can be board certified in American Academy of Lifestyle Medicine. And we are also in the process of getting grants from the Lifestyle Medicine group so that we can be funded and we can spend enough time with our patients. So what is lifestyle medicine? Lifestyle medicine actually has 6 pillars. And let's talk about those pillars, and then let's talk about how we can translate them into myositis-specific actions. So these are the 6 pillars. And so nutrition is one of them, and Dr. Gupta is gonna give us a very detailed lecture about that. Physical activity, definitely. And Dr. Sari is going to talk about also. Stress, managing stress is another pillar. Relationships is another, connections, sleep, and avoiding dangerous substances such as smoking, drugs, and alcohol. So I'll briefly talk about nutrition. The American Academy of Lifestyle Medicine recommends a whole food, plant-forward pattern, nutrition, and like based on vegetable, fruits, legumes, whole grains. And American Academy of Lifestyle Medicine, again, suggests that we maintain our protein intake, because protein intake is also important when we do our exercises, physical therapy, to maintain our muscle mass. And there is also this notion that we can get that protein from meat, which is not accurate. And that's what American Academy of Lifestyle Medicine is suggesting. But when I counsel my patients, I never tell them, you have to be a vegetarian tomorrow, and that's the only way forward. Of course not. Everything is on moderation, but whatever you can do to improve your health. And of course, limiting ultra-processed foods, which is probably like tougher for us in the US. You guys are better here. Of course, when we talk about nutrition, we also talk about dysphagia and what we're supposed to do, refer to speech therapy, maybe texture modification. And of course, an excellent lifestyle medicine clinic is going to be a multidisciplinary clinic. So your neuromuscular specialist is going to be there in one room. The next room is going to be your speech therapist. In the next room, your physical therapist, your nutritionist, social worker, and your pulmonologist. So all of them will be in the same floor or in the same clinic. But if not, at least if you have good interactions or connections with all these specialists, it's definitely going to make a big difference in your patients or in the patient's care. And that's what we're trying to do in the U.S. and especially at UT Houston, Texas. So pillar 2 is exercise. And the evidence, and we have experts here, Dr. Anderson is here, so structured endurance and resistance training improves strength, endurance, and quality of life in myositis patients. Unfortunately, still in the U.S., there's this notion that exercise is dangerous. And I get a lot of patients, they come to me, they're like, oh, Dr. B, my physician or therapist told me to stop exercising because of inflammatory myopathy, which is, now we know that is not accurate information. We need to guide our patients and we need to customize their exercise program. And again, as physicians, we have to start the process and we have to collaborate with our physiotherapists to plan the perfect exercise schedule for our patients. And of course, initially, this needs to be supervised so we can route for our patients, we can cheer for them, because one of the main reasons why the patients cannot sustain, yes, there are several barriers, like getting there, maybe you need to go to your therapist at least a couple of sessions. Sometimes affordability, there are several things that can factor into. But one of the big reasons why our patients cannot sustain exercise is because they start and then they lose the habit. So initially, if we supervise them, the adherence is going to be better. And then that's also what we're working on. We're working on an app. Again, we work with Dr. Anderson again and UT Houston, Rice University in Houston, and Karolinska Institute. The app is ready, but there are some bureaucratic obstacles we're trying to overcome. In our institution, there is some legal jargon that we have to come out with. But the app is ready, and then the idea is with this app, we're going to recommend the exercises, and we can see on the dashboard what our patients are doing, and we can cheer for them, and we can basically monitor them and also help them through their exercise journey. So I'm gonna, since I think Fulden, are you gonna talk about exercise, right? So I'm not gonna go, more facial. But the idea is at least like weightlifting 2 to 3 times a week, more if you can. And initially talk to your patients or ask your doctors what type of exercise you're supposed to do. And again, the next day, if you're completely tired, in pain, then it means that you've done too much, so you need to take it down a notch. So it's going to be something that you're going to optimize and customize with your provider. But we know that it has to be a combination of resistance training / weightlifting plus cardiovascular exercise. Pillar 3 is sleep. So we have to sleep at least 7 to 8 hours. So now we know that there is also a system, like a lymphatic system that we have in our body. We have this lymphatic system in the brain, and that system helps us to get rid of the toxins. And when does that happen? At its max, it's when we're sleeping. So sleep is really important, and we have to get at least 7 to 8 hours. Sleeping more is also not useful, and sleeping less is not useful either. And we have this notion again, we have to work hard, really hard, to the extent of maybe pulling all-nighters and maybe not sleeping. I think in medical school we all wore it as like a badge of honor, which now looking back, that was not a very smart thing to do. Now we have definitely more information, scientific information about that. And I remember in school we had this class, and there was even one class, the babies need like these many hours, 12, 13, like some, and then if you're like a researcher, scientific researcher, you're okay with 4 or 5 hours. So that was something that was ingrained on us, I guess, which is not true. So we have to fight this and get our sleep, definitely. So recently, I purchased a couch for my office, and without any shame, like if I have to take a 10, 15 minutes nap, now I tell my nurses, I have to get a power nap, and then I come back much more invigorated. So pillar 4 is stress, and I don't really know how to really address this. We're all under stress. Our microenvironment now, unfortunately, the macro environment, it's very stressful, but we have to come up with daily practices to help with that stress, be it meditation, journaling, paced breathing. Breathing definitely helps also, because when we breathe, we also slow breaths. We help with our parasympathetic system. We activate our parasympathetic system. We calm down. And that's something you can definitely practice. And there are all several apps, and some of them free apps, that teach us meditation, teach us breathing. Journaling is another one. And if you, and based on our beliefs, if we're religious, praying is like meditation, whatever makes you happy or makes you feel like you're in that flow, and you can focus on now. That's going to be great. And time in nature, definitely looking at water, looking at trees. If you're living somewhere like that, that's great. In Houston, we don't have any water, but we have a lot of green trees, and that's what we try to do. So pillar 5 is risky substance avoidance, and thankfully with the awareness of that tobacco is bad for us and alcohol is bad for us, it's, I think the young population coming, they're actually better, but tobacco, alcohol, and drugs is the other pillar that we have to focus on and discuss with our patients. And pillar 6, it's socializing. And I don't know if you know about these blue zones. There are these 5 zones in the world, and they looked into these clusters of people, and there are so many people they're reaching their 90s, 100s. And when they reach that age, they're not actually at home, basically not interacting with their friends, but they're biking, they're actually exercising, they're working in the yard. Their dementia risk is lower than the average risk. So they looked into these clusters of people, and then that's how actually American Academy of Lifestyle Medicine came out with these 6 pillars. And one of the pillars that we're talking right now is social. So that's being connected. And I think we realized this during COVID. Before that, again, in the US, we're very supportive of individual approach. You know, the father, the mother, and then the kids, and then that's it. And then we put the kids in our cars, carpool over the weekend. We drive down from this activity to that activity. And then during COVID time, we realized that wasn't like isolation isn't actually such a good thing. And we all realized how interaction, talking to our friends, family members, actually it's such an invigorating thing that we do, and we take it for granted. And also in these blue zones, they noticed that all these clusters or these people who lived to be 100 in a healthy way, they had this social connectedness. They had groups of friends, and maybe they went to their church, synagogue, mosque, or they went to these like knitting groups, like whatever you connect with. And in Okinawa, Japan, Okinawa is one of those blue zones. Apparently they have this group. So you basically come together, and since very young age, this group of women, and they take care of each other. For example, one is in the hospital, the others, if they need any financial support, they fundraise among each other. So you have these 5, 6 women, they're your wing women, and then they go through life together. So social connectedness is also really important. And again, enlisting maybe a movement buddy. That's also, you're going to talk about what you're doing, what you're going through during your life. And at the same time, you can support each other to do exercise. And that's going to help with the disease. So those are the 6 pillars. And basically, when our patients come in, we have to talk about these 6 pillars with our patients, not just, okay, so how are you doing in your myositis? Okay, this is the medication, take your prednisone, IVIG, this and that, increase the dose, and then let me check your strength, and then you're good to go. No, we have to talk about all these 6 pillars because those are also important in our patients' prognosis and how they respond to our treatment. And also, it helps with adherence of our recommendations. And our patients also need to ask these to their doctors, and they need to request and actually demand that we provide care like this. We have to change how we provide care. And of course, it all also, when there's demand, the system has to change. Other special issues in myositis patients, photosensitivity, of course, always we talk about sun protection, fall prevention is important, and that goes with exercise. This is something that I always discuss with my patients, what can we do? And then if any breathing issues, of course, talk with our respiratory therapist and then determine what they need. So this is like a 12-week lifestyle plan that we can start, and then we can basically escalate every couple of weeks. And of course, if our patients they need more support, or they use a walker, they're in a wheelchair. So we basically customize our program and then take it from there. So we can come up with this lifestyle plan, talk about the nutrition, talk about the sleep, talk about exercise, all of that. So you can ask your physician. So they can give you questionnaires. You can ask your physician, hey, I want to talk about my sleep. If you don't have really enough time, a lot of time, why don't you come out with these like questionnaires? There are sleep questionnaires. We give our patients these sleep questionnaires, and I can fill that in beforehand. I can fill that in my quality of life, my depression scale, all of that we give to our patients. And then again, shared medical appointments. The way to move forward is base the clinics on these 6 pillars and also do it in a multidisciplinary way. Multidisciplinary clinics, we have a lot of evidence. For example, for our ALS patients, there is really good data that a multidisciplinary clinic actually improves the longevity of our ALS patients and also their quality of life. I definitely believe I'm a big proponent of multidisciplinary clinic, and if there is room, of course, it depends on the logistics, funding, all of that. But a multidisciplinary clinic where we're going to address these also 6 pillars is the future and is the way to go. And that's definitely going to improve patient outcomes and our patient also satisfaction rates too. And then for physicians, we can basically, now we're using electronic medical records. We can come out with dot phrases, smart texts that we can work with our IT system and build them so we don't spend much time like documenting every time. So exercise is treatment and is medicine. We always say that. A plant-forward nutrition is recommended, and sleep, stress, social connections are important. And if there are any patients struggling with tobacco, alcohol, or drugs, we have to also talk about that and help them get the necessary counseling. And again, we need to start small and measure what matters. Start from somewhere and then take each day as it comes. And then at the end of the day, I have a sign in my office and it says, you did what you could do, the best you could do. So stop thinking about today, wrap up today and move on. And now move on to the next day. So that's pretty much it. We have time for questions.
Thank you so much, Dr. B. I do want to say I think at UT in particular, you and Dr. Eleni Teniakou are building a model interdisciplinary clinic, and we'll all be watching that closely for these types of really forward-looking, patient-centric, holistic approaches to managing myositis. So Linda has a microphone here. If anyone in the in-person audience has a question, please raise your hand. We do have a couple questions coming in from online, so we'll start with one of those for Dr. B. Is it more important to add healthy habits or to eliminate unhealthy habits?
I think both are important, but I think if you eliminate unhealthy, that would be my priority, because I see it, if you don't eliminate unhealthy, we're trying to fill the pool from somewhere and then losing it from the other end. But of course, if you could do both, that would be great. But first, eliminate unhealthy step by step, and then focus on building in healthier habits.
Thank you. Seems like sage advice. Any questions here in the audience yet? Over here. And while we're getting the microphone over there, Dr. B, are the 6 pillars in order of importance? Like number 1 being first priority?
I think they're all important, honestly. As I said, if you have a bad habit, and then we're trying to, for example, if we're smoking, but then we're also eating healthy, still we're going to get coronary artery disease. And that also increases our risk for Alzheimer's, lots of things, cancer. So I really don't see them in like, oh, this is much more important. Of course, exercise also is something dear to my heart. I might be guilty of spending more time talking about exercise. And also it depends on what each patient needs. Maybe one patient has gotten the grasp of it now, is an expert on exercise, but then needs help with social connections, feel lost, doesn't know where to go, what to do. Then maybe we might spend more time talking about that.
Thank you so much. Very helpful. And I think part of that holistic approach is recognizing that not every patient is the same, right? And so not every approach to care management should be the same. So the 6 pillars in the order of priority that matter the most to the patient. Please, the question from the audience.
Thank you so much. I just wanted to ask, how is this resonating with your patients with more of this multidisciplinary approach? And I saw on there that you had like group patient visits. And I actually participated in something similar when I was pregnant. It was called centering in the United States. And it was like a group approach for all of us to have our prenatal care in a group. And I was a little hesitant to do it at first. And then it was actually I have made a connection with women around, the same gestational age as me. So just wanted to get, how are patients relating to this, and are they open to it? Is it something, that they're not sure about at first?
Yeah, everybody's different. Some of our patients, they're more private and they're a little bit sort of hesitant, maybe shy. So with those patients, I basically go over everything during visits. But I tell them during group visits, like, come and then see if you like it or not. And you don't have to continue, or you can leave. But honestly, like, patients really love group visits. And I love group visits too, because I learn a lot. Because we all learn from each other. And then one of the patients will tell me, oh, I do this trick when I have this problem with my swallowing, or with this exercise, I developed this, and you can do it like this in a chair, better way. So it's amazing how much we learn from each other. And I think patients really love that and appreciate that. And it's also, I think, good to see there are so many others going through the same difficulties that I'm going through. Most of the time, it's very positive.
Thank you so much. Great question. Thank you, Dr. B. We could take maybe one more question, but we do need to be transitioning to the next section of our workshop, which, as Dr. B described, will be Dr. Gupta sharing in detail about nutrition. So food and diet questions, you can save those for our next speaker. Thank you again to Dr. Balichalar.
Thank you, Dr. Balichalar. And now we are moving to the next section, and we will welcome Dr. Latika Gupta, who is talking more about nutrition. And you are a consultant rheumatologist at Wolverhampton Hospitals and in Manchester, or this is Birmingham, sorry about that. But I just want to say welcome, and you will go on talking about this interesting matter. Please.
Thank you very much, Annalie and Paula, for inviting me for this session. And it's truly an honor to be here with all of you and talk about something I feel very passionate about, as some of you may know already. I firmly believe that we don't treat the disease, we treat the person holistically. And some of you may have heard of the syndemic construct of disease, which means what a person has together with the disease and their environment. And outcomes are typically determined not just by the disease, but also the wholesome picture. So if a person has an adverse environment and a bad disease or even a milder disease, they may have a worse outcome. So this is where the different pieces of the puzzle come together, and diet and nutrition is one important part of it. We all know that myositis causes muscle inflammation and there can be fatigue and pain. So we're going to talk about evidence regarding all of these. And treatments also come with side effects, which can be troubling. So diet is one of the most commonly asked about questions, at least in my clinic. And often I have extended slots talking them through diet and how they can exercise. So dietary guidance is quite standard in some diseases like diabetes, heart disease. It goes hand in hand with management of the condition. And even other autoimmune conditions, if you look at rheumatoid arthritis, there's a lot of evidence emerging that certain diets are better. So we dealing with myositis are somewhat far behind in doing that, and hopefully with this workshop we're going to bring in some change. Unfortunately, there are no specific dietary recommendations at the moment, but some work is being done in this space, and we're going to look at that today. So when I started thinking about this, and some of you know, last year I had a lot of discussions with some of you around this, I wondered what are patients discussing about diet, and maybe we can go online in the patient communities to look at that. And what does research evidence actually show? And what would diet look like in a large myositis group, and does it relate with outcomes? So together with Professor Kirchhoff here in the audience, we did this work on Reddit, looking at a discussion among myositis patients and also muscle dystrophy patients. So any muscle disease community, and we looked at 26 billion posts from Reddit data dumps and filtered down to 18,000 posts, which seemed to be related to muscle conditions from 7,000 authors. And eventually, after a lot of data cleaning and rigorous control, there were around 400 posts by people with myositis or suspecting it that mentioned diet or nutrition-related terms. And as we can see here, they wanted to discuss diet or protein. Sugar came pretty high up as well. And then vitamins, gluten, and magnesium, and then oils. So most common term was diet and other components as well. So it seems like patients are trying to actively self-manage through nutritional choices. And when we looked at a diet-focused semantic network, you see there are 3 different themes. So they talk about the most common ones being whole foods and protein sources, and supplements and deficiency testing was also pretty high up in their concerns, and then macronutrients and specific diets, as we've been discussing in the TMA as well over the last month, like gluten, dairy, inflammation, and experimentation with elimination diets or even the anti-inflammatory diets. And we further went in to look if there's any difference in the different muscle conditions, like muscle dystrophies versus myositis. So lots of things were in common, but there were few themes like gluten or the micronutrients. It seems that the myositis patients were more worried about that, while creatinine and those that were more discussed in the muscle dystrophy groups. And maybe we will see from the next, some of the unpublished data why that is the case. So key takeaway from Reddit is that diet is a central concern for patients, and they're focusing on correcting deficiencies or managing medication side effects and also reducing inflammation through food. But are they getting good evidence to guide them? Well, let's look at the research. So together with colleagues, I conducted a systematic review and looked at 52 studies on nutrition-based therapies in muscle disorders. which included myositis, muscle dystrophy, metabolic myopathies, and other myopathies. And this was a cross-disciplinary effort, including rheumatologists, neurologists, dietitians, and patient research partners. This is just a workflow chart. I'm not going to bore you with that. But as you see, there were very few studies on myositis. And there are quite a few studies in muscle dystrophies. There is some evidence to support certain treatment. And in studies in myositis, mostly focused on creatine supplementation, a study done by Helene, who's here in the audience, and branched-chain amino acids, high-protein diets, and combination of exercise and supplementation. If you look at the risk of bias of included studies, so this is like looking at the quality of evidence. So green is good quality of evidence, and yellow is in between. So we had reasonable quality of evidence, but some of the studies probably didn't make the cut. And disease states with positive outcomes. So most of the positive studies were in Duchenne's or mitochondrial disorders and GNE myopathy or McArdle's. So very few RCTs specifically looked at inflammatory myositis, and the main interventions tested were creatine and branched-chain amino acids. Most common outcome measure looked at was muscle strength, and most studies reported no significant change. One study, creatine plus exercise, improved functional performance in polymyositis and dermatomyositis. There was a 13% improvement versus placebo. There is evidence of creatine supplementation in Duchenne's and ketogenic diet in McArdle's disease, and whey protein in critical illness myopathies. So the bottom line, some promising signals from certain supplements like creatine, high protein diets, ketogenic diets, coenzyme Q10, but these are in different conditions, not in myositis at the moment, so maybe far more trials are needed, and there's a major research gap, and we perhaps need large multi-center RCTs with standardized outcomes in myositis specifically. Now, we were talking about plant-based diet, and what is plant-based diet? This can be different kinds of diets where plant-based foods are the most common ingredient, and med diet is one of the plant-based diets, although not purely plant-based, and med diet is one of the most studied dietary patterns in medicine. It's rich in olive oil, whole grains, legumes, fruits, vegetables, and fish, and it is known to reduce inflammation, CRP and IL-6, and improve cardiovascular health and metabolic function. There is rationale for myositis as well, because we need anti-inflammatory effects, we need antioxidant effects, and it's likely to support mitochondrial and muscle health. But it's not been formally studied in myositis at the moment. So we administered a survey to a group of patients. So there were 4,500 respondents who completed the 14-item MEDA screening score, which is a Mediterranean diet adherence scale that has been validated. And of these, around 850 individuals had myositis, and 3,000 had other rheumatic diseases, and 500 were healthy controls. We looked at the dietary adherence, and then we looked at their physical strength and pain and fatigue and life satisfaction. Who were these myositis patients? So most of these were around, the median age was 61 years, female predominance, and also predominance from high-income countries. And most had disease duration of 7 years, and 46% felt that they had active disease. And quite a few had other comorbidities as well, which becomes important because of the ancillary effects of med diet in these conditions. Now, as we see here, so overall adherence was modest. So some people adhered, some did not, as we would expect. DM and necrotizing myositis patients seem to adhere more than IBM. And high MEDAS was associated with better physical function, better global physical health, and higher life satisfaction. Disease activity, damage, pain, fatigue trended downward with people with higher adherence. When we looked at clusters of different patients, so it seemed that the younger group, who was around 55 years, so had lower disease activity and damage, lower fatigue and pain, lowest comorbidity, and better adherence. And then cluster 2 was older and had everything in the other direction. So what does this mean? Maybe patients with more severe disease and functional limitation are also the people who have worse dietary adherence. This may also be because of their disability, but there is potential that this may benefit them the most. And maybe they have barriers like fatigue, limited mobility, and dependence on caregivers. And this is where targeted dietary support in the clinics could make a big difference. So to summarize, patients are already actively seeking dietary guidance, and evidence base is thin, but it is growing, and there's some promising leads from creatinine, high protein, and maybe med diet. And a better med diet is associated with people with less fatigue, pain, and better physical function. And those with most severe disease have the lowest adherence to these diets. So there's a window for intervention. Thank you. And I would like to congratulate the TMA and Linda for putting together the Nourish Autoimmunity Challenge, thoughts from the group, and we are waiting for the results to be announced, keeping our fingers crossed. So thank you to all who participated in this effort.
Thank you so much, Dr. Latika Gupta, for this very interesting presentation. And as you noticed, you said that patients with myositis, they are very, very interested about this subject, this myositis, or more than half of the people who were asked answered that is interesting. And I think there should be much more studies done about the diets and nutrition to find out more what is actually true. So before we take the question, I wanted to add some small facts, some little tips, how you can make it a little bit better, choose your own ways to change your habits and so I move forward. About the nutrition. Latika was talking most of the Mediterranean coast and the benefits for cardiovascular diseases and oral health. And then I just want to mention the other types of diets like this anti-inflammatory protocol, because the picture you see here is the Swedish magazine for the patients from the Swedish Rheumatism Association, where the patient who has ankylosing spondylitis is showing how this anti-inflammatory protocol program has helped him to get better and get rid of his pain. And unfortunately, there is not so much evidence about this, but there are some studies done with other rheumatic diseases, not myositis, but for example, this pilot study in New Zealand that shows that 12 weeks intervention significantly improved in pain and fatigue and exhaustion and sleep, and many testimonies of patients with other diseases like lupus also shows that they have been helped by this diet. But kind of hard to follow because it's very restrictive. You have to remove a lot of things, like you start with the sugar and the carbs and a lot of things, and there you have to get some help to follow this diet if you want to do that. But it might be worth trying for some people, I don't know. And not only these fats and the cholesterols are very important for your cardiovascular health, but also the sugar, your blood sugar. And this is a little thing you can think about if you want to avoid these peaks that is not very healthy for your health, because it's not only for the diabetics, but all the patients. The little picture I show here gives a hint on what is this little change in your time eating will do. This eat your greenies first. If you do the same, if you eat the same meal, even if it's not so healthy, it's more healthy if you eat your greenies first. You make a salad, don't take the salad as a dessert, eat it at first. And it will get in the stomach and put a layer in the stomach that makes that the food you are eating afterwards gets absorbed more slowly. So this is something. Also, this type of eating might affect this GLP, the satiety hormone that guts release in response to meals, which these medicines that they have been speaking so much now, Viii and Ozempic, so which are mimicking this GLP-1 hormone, which was in the beginning was produced for these diabetic patients, but now it's also used for obesity, to lose weight. So just some little things, because I was having some discussions with my husband, because he's also baking this sourdough bread, and I told him it is the same flour, wheat flour, it can't be more healthy than eating the white bread. And so I was wrong. I found this, so I wanted to share this thing. Do the sourdough bread, and it has lower glycemic index than white bread, so it will be absorbed more slowly. And also it has other benefits because it doesn't have these anti-natural factors that the whole wheat or grain breads can have that are affecting the absorption about the vitamins and iron and things like that. And this is not just changing the whole diet. If you are a fan of your things, your meat and your hamburger, just change the French fries, and you can add some salad instead. So it will be much, much healthier, so you can keep on eating your hamburgers. And they have been talking a lot of the supplements, and you might think it's a good thing, but you have to be very careful. If you go into these health stores and look at the bottles, it always says holistic on the bottles. So don't do them, get the wrong idea and think it's very healthy. About wanted to say something about vitamin D, because people in the Nordic countries, they got lack of vitamin D in the winter time, and you have to get some more maybe, because it's important for your bone health and for the absorption of the calcium that you need for the bones also. And some interesting things is about this aging. You know your chromosomes that you have in every cell in your body, and the ultimate ends of the chromosomes are these telomeres, and they get shorter and shorter by every division of the cells. But vitamin D might be lowering this risk, and we could say it may delay aging. And there was a third thing I found about vitamin D might be lowering the incidence of this autoimmune diseases. And the figure they gave me, 22%, I think it's remarkable. So we should look more of that, because that's very, very, very remarkable indeed. Talking about the gut microbes, they are important for your health in many ways, and you can affect them. You should feed them with good stuff like fermented food, fruits and vegetables, cabbage and kale and things like that. And the bacteria you have, it can affect your mental health. It keeps mainly healthy signaling to the brain. And also good sleep and active lifestyle is, with exercise, is very good for them. But what is the bad thing? Like always, red meat, saturated fatty acids, and ultra-processed food, as we had also already talked about. And what is the worst thing for the gut microbes? The antibiotics, of course. Not the usual ones, penicillin, but there are some narrow-spectrum antibiotics that are so dangerous that you can see the effects after they had done some studies. It was seen after 8 years you didn't repair your gut microbes. So I think instead of doing more studies over a longer period, they should just put their bags together with the industry and who is doing this probiotics and find out what kind of gut microbes you should be having in them, so you can repair the damage done. And this interesting thing about the epigenetics, everything we have been talking today is actually about this epigenetics, and because you can, the genes you have them always, but you can turn them on and off with the things you do. You can behave it like we have. Now we know that exercise will affect the gene expression, so that you can actually shut down the harmful cytokines in the muscles. At the same time, you can affect with your food choices the gene expression. That is very important to think about. So what you eat matters very much, and what you feed your gut microbes also matters very much. And there is a lot of things you can do about this. We will have now we have some time for questions. So we'll see if Paula has...
Yep. I think we only have time for 2 questions, one from our online audience and then maybe one from the in-person audience. So Dr. Gupta, if you could quickly address, the 2 folks online have asked for the difference between the autoimmune protocol and the Mediterranean diet, if you don't mind explaining that, please.
Well, disclaimer, I'm not a dietitian, so may not be the best person to talk about it, but it was a med diet. And so Mediterranean diet is essentially more plant-based, but you are allowed to have milk-based products and some meat products, but it's more containing seafood and very limited meat and a small amount of like cheese and stuff like that. So it's not purely plant-based in that sense, but autoimmune protocol, I haven't looked into the specifics, but from what I understand, you eliminate certain items based on the belief that they trigger autoimmunity. So like the FODMAP diet is also like elimination diet, but autoimmune protocol has different elements to the FODMAP diet. Thank you.
Thank you. If both of you could stay here, please. We have time for one question from the audience here in Auditorium 8. So if you have any burning questions about nutrition, whether for Dr. Gupta, who has shared with us some of the research, or for Annalie, who has shared some of her own hard-won expertise living with myositis and making dietary choices. Last call. Okay, then Annalie will introduce our next speaker for the final portion of the workshop.
Thank you so much.
Should we have another round of applause first?
So now we are going to have with us Dr. Fulden Sari, who is talking about the effectiveness of face yoga in chewing and swallowing problems. And we are going to have an interactive demonstration also, which will be very, very interesting. So I leave the word for you.
Thank you. Welcome.
Thank you, Annalie. Thank you, Paula, for this invitation. And I'm really grateful here. And today I talk about face yoga in chewing and swallowing problems. No conflict of interest. My presentation comprises of two different parts. First part, I will give information, dysphagia and swallowing phase impairment, and then explore whether face yoga can have functional in rehabilitation program. Second part, we will do together face yoga practice. Swallowing is a complex neuromuscular process that requires a precious motor coordination of larynx, pharynx, and esophagus. Smooth gluteal muscles are located in the lower and middle part of the esophagus, but the upper part, esophagus and oropharynx, comprise of striate gluteal muscles, which is affected by inflammation. And we know that myositis targets striate gluteal muscles. For this reason, increased dysphagia risk in myositis patients. The prevalence of dysphagia becomes more frequent over time, but it can be also initial stage or even only symptoms in patients. So dysphagia shouldn't be considered only late stage symptom. That's important. And myositis can result in impairment in oral phase, pharyngeal phase, and esophageal phase. Specifically, pharyngeal dysfunction is strongly linked to aspiration. In these pictures show the clinical swallowing pattern in myositis, actually IBM patients, one IBM patients. In this, do you have any here? This? Yeah. Okay, better than. This picture shows the clinical swallowing pattern in IBM patients. First, oral preparatory phase. During this phase, facial and masticatory muscles is here between ear and the end of the teeth, and it's important to chewing process. When masticatory muscle weakness may lead to poor oral sealing and slow mastication. Second part, oral transport phase. Oral transport phase, tongue weakness may impair bolus propulsion toward the pharynx and resulting in delayed oral transit. The other phase, pharyngeal phase. In this phase, patient can experience reduced upward movement of throat structure, incomplete airway protection, and unfortunately increased aspiration risk in patients in this phase. The last phase, esophageal phase. Esophageal phase, patient may experience esophageal dysmotility and making it harder for food to move toward the stomach. In the literature, there are some approach to dysphagia for patients, pharmacological, non-pharmacological treatment, and invasive treatment. In this section, in this presentation, we focus on non-pharmacological treatment. Non-pharmacological treatment in the literature or clinic, Mendelssohn maneuver, exercise, expiratory muscle strength training, or dietary modification there are. But to our knowledge, unfortunately, there aren't any study investigating face yoga and swelling problems in myositis patients. Why consider face yoga? Because face yoga supports facial muscle straightening and helps neuromuscular re-education and motor coordination training, helps muscle tone regulation and relaxation, and engagement of lip, tongue, cheeks, and suprahyoid region. That's important. And it comprises of many different patterns. These patterns are facial muscle exercise, control breathing pattern, stretching and relaxation, and postural exercise, and manual stimulation massage techniques. And it's really complicated, and it is useful many pattern in patients. We say that in the literature, there aren't any study in myositis patients, but in the literature, we investigate there are some studies related to the other groups. One of the study, there are investigate face yoga and swelling related muscles. This study was conducted in middle-aged health women groups, and they focus on two swelling and chewing muscles. One of them, buccinator muscles. Buccinator muscles is this part. And these muscles, after treatment program, they found that buccinator muscles increase muscle tone and functional activation and enhance lip and cheek muscle strength. And they emphasize relevant for bolus containment and oral fuzz control thanks to face yoga. And the other muscles, the gastric muscles, is suprahyoid muscles and helps specifically oropharyngeal process. And they found increased tonus and stiffness and elasticity. And these muscle strength improve. And then potential contribution to hyoid movement and swelling mechanism. We have some take-home message. Dysphagia is common and clinical significant because sometimes patient has subclinic problems for dysphagia, and face yoga induces adaptive change in facial and suprahyoid muscles. Targeted lip, cheek, chin, and movement may enhance oral fuzz control and hyoid function. The last take-home message is face yoga may represent a low-risk adjunctive strategy in dysphagia rehabilitation. And now, let's start to practice together. I need only 1 minute. And then I think that first, let's sit comfortable because unfortunately I see someone collapse on chair. Please, let's sit comfortable. Okay. And you checked your body. Maybe you close your eyes and you checked your body and your face, your chin, your tongue, your throat, your shoulders. If you feel any spasm, please relax this part. And now close eyes, please. And now here, take a deep breath in and breathe out. Again, breathe in and breathe out. The last time, breathe in and breathe out. Slowly open your eyes. And now we will start some posture exercise. And your shoulders, lift your ear and rolling back. 1, 2, 3, 4, 5, 6, 7, 8, 9, and the last time, 10. Relax. And now, put your hand on your chest and stabilize here. Then forward your chin and back your neck. This position. Here, stabilize and chin forward and back neck. You feel these muscles. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Relax. Amazing. We will do again, but we add our tongue. Why? We know that dysphagia problems affect tongue movement, and it's important for oral transportation. And now, the same position, put your hand on your chest, and then tongue stick out to noise, and back neck. Good. Hold here. Yes, hold here, back neck. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Relax. Good. We work again tongue, but not this. Actually, in your home, I have limited time, so I will show I want to show many movement. So 1 repetition, but you can do safely in your home daily time, and at the same time, diagonal left and right you can do. Okay, notes. And now, tongue is important, so again with tongue. Now, vacuum your tongue to roof. this. Yeah, and hold. Directly vacuum. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Relax. Amazing. Okay. And I'll say, okay. And your index and middle finger on the temple and the other fingers down. In here, lift and diagonal upward here. And we will say some sound. A, O, E, I, O. Okay? Okay. Repeat, please. A, E, I, O, U, A, E, I, O, U, A, E, I, O, U. Amazing. And now relax. And now we have, we need, Paula need, yeah, serum. And please take enough serum in your, intake your hand and please warm. And then put your chest, face, throat. Okay? Please, everyone takes enough oil and then warming. And your chest, throat, face. You feel this oil, this serum. I think that everyone takes. No. Okay. First, massage. Back your hand and sweep your throat. Because we work our neck muscles and relax, you feel all of the neck part. Good. The last time, please take. You feel your neck muscles. Okay, good. And now, your middle, not middle, thumb, your thumb fingers under your chin, and you feel your chin bone. This position, and from middle to ear, you feel your suprahyoid muscles. 1, 2. Please take here. Your middle, not middle, thumb finger under and middle chin, and then you take and pressure suprahyoid muscles. To ear. Okay, 1, 2, 3. Please, everyone. 4. Ingrid, you take all of them. Yeah, here. Yes, better done. Thank you. And the last time. The last time. Good. Now, the same position, but your thumb under your chin, your index finger above the chin, and you will take from middle to masseter. This. Yeah. 1, 2, 3, 4, 5, 6. Bilateral. Please bilateral. 7, 8, 9, and 10. Okay. Now, we will do massage for our masseter's muscles. We know, because I explained in presentation, masseter is important chewing muscles. And actually, not only this is, recently you have stressful, and when you wake up, you feel yes, pain. Actually, masseter spasm pain mostly. So I will show you 3 different masseters massage, and you feel pain in your masseters. You can do safely yourself these muscles. And firstly, where is masseter? Masseter is clench your teeth and here. Clench, please, and then touch your masseters, these muscles, and between ear and the end of the teeth, masseter's muscles. And now we will do massage these muscles. Soft fist your fingers and open your eyes and correct, here. Anneli, not here, here. Yeah, this is, okay, good. You feel your muscles and you feel this pressure on your masseters. Open your eyes, all massage process. The last time. Okay, amazing. The other masseter's muscles, make your fingers a C shape and thumb finger under the chin and stabilize here, and index fingers and with pressure open your mouth. Yeah, someone say, oh, I think that your masseter is spasm now. And I have good news, you will be better than after presentation. 2, 3, 4, and the last time, 5. Perfect. And the other part. 1, 2, 3, 4, and the last 5. Perfect. The last masseter's muscles with fingertips. You will take your fingertips, your masseter's bottom to up. Yeah. You feel your masseters and relax. First time you can feel pain because of masseter spasm, and don't worry. For a while, you feel this relax there. The last time. Perfect. And now bring your hand and up. You feel your vertebra and side, the other way. And make your hand Namaste, and slowly coming. Namaste. Thank you very much to join me. And if do you have any questions for facial yoga or this facial rehabilitation, you can contact with me this mail or this QR code. And I have good news, the other good news. We planned in myositis patients face yoga and swelling, chewing muscles activation. And I hope that next Gcom conference we will share with you. Thank you.
Thank you, Fulden. This was very interesting and wonderful. We are running out of time, unfortunately, so we cannot take any questions now, but you have left this QR code, so you can send the questions from to there. So we have to move on and wrap up now. And we want to ask you about your tips for what do you... Okay, something happened with the slides. Thank you for the... Okay, there we are. Oh, so we want to have a little voting. So you have these Mentimeter apps. Do you find this?
You have to push this.
Yeah, thank you. Oh, but
It should be coming. Here it is now.
okay.
Minty needed a moment of facial yoga also. Okay. Your best tips for optimal living, optimal well-being. Annalie, what are some of yours? Hobbies, crafts?
Oh, yes. Outside activities, sauna bath. This is because I am from Finland, so I have sauna bath. It's my best thing.
Lucky.
I put the ice bath there too because I have one patient who is a very dear friend of mine who is doing this and taking ice cold showers every morning, and she says that she's feeling very well with that.
Wow.
I wouldn't do that.
Nobody has put that in the Minty yet. How about gardening, though? Do we have any gardeners?
Yeah,
Ooh,
sure.
okay, Leah. Prayer, that's good. Dr.
Yeah.
B touched on that as a form of mindfulness.
And the adventure doesn't need to be climbing a mountain somewhere. It can be small, small things. You just look out of your window and maybe you see some nice little bird or some animal that is not so common.
Awesome. We have a few more replies coming in, but I think most of the audience has participated. Thank you so much. We did also prepare some suggestions based on what we had collected from our patient advocacy organizations.
Yeah. Okay. There you have the pictures. So,
And this is our take-home message, our final take-home message, based on everything that we have learned holistically today.
yeah. Do the things that you want to do, what you feel that gives you well-being, and stick to it. So I think our time is out now.
Thank you. We hope you'll join us all for the next patient-led content is a workshop focused on CAR T therapies at 5:30 or 17:30 local time. In between now and then, of course, is the official conference welcome and introduction, the first poster viewing, and a coffee break. So we look forward to networking with you all. Thanks again for joining online as well.
Thank you all.
Good afternoon, everybody, and welcome to this patient-led workshop on chimeric antigen receptor-based therapies, or CAR therapy. We are excited to spend this precious 1 hour on patient perspectives in navigating this new type of treatment in myositis. My name is Karen Cheng. I'm a patient living with myositis. I have anti-SRP positive autoantibodies. And my co-chair today is Guillaume from France.
Hi everyone, I'm very happy to be here for this first Gcom for me. So like Karen, I'm also a patient living with myositis. I have also anti-SRP IMNM, and I'm very excited to be here to facilitate this session with Karen and 3 amazing speakers.
Before we begin, a couple of requests. Please silence your phones and other devices. And this presentation is being recorded, so photographs will also be taken. If you do not wish for this to happen, please let us know or one of the staff know. For those of us who are joining us virtually, we very much welcome you from all over the world. Please use the chat box on your screens for any questions, which we will take at the end of the session. Patients in the audience, please be mindful for those professionals in the audience, if you're asking questions, to use lay language as well. And finally, please keep your questions also very brief and leave the room as you found it today. We will first hear from our patient, Lindsay Günzel. She's a patient who has undergone CAR-T treatment last year for her anti-synthetase syndrome. Our clinical leaders, Professor Pedro Machado and Dr. Rebecca Nicolai, will tell us about their experience with treating patients with CAR-T. This will be followed by a question and answer session with all speakers, and also patients or participants joining us online, please text your questions into the Q&A chat. And finally, we will close with a very short poll. So please make sure that your phones are ready for scanning the QR code. Without further ado, welcome Lindsay Günzel. She will tell you her story about having CAR-T.
Thank you, Karen. As Karen mentioned, my name is Lindsay Günzel. I am from just outside of Minneapolis, and I am very proud to call Minnesota my home. My disclosure statement, I'm a consultant and speaker for Picnic Health, a health technology platform. I was diagnosed with dermatomyositis associated with anti-synthetase syndrome in March of 2023. I am positive for the JO1 antibody. I dealt with a lot of skin issues, including rashes right away, along with some interstitial lung disease involvement. But the dominant force throughout my journey with DM and anti-synthetase syndrome has been muscle weakness and then mechanics hands. Below, you can see all of the treatments that I've tried over the last 3 years. And if you are a patient, you can attest to all of the lovely side effects that come along with all of those. So I'm going to focus on a few things that I've learned through my experience. And because the majority of patients who'd be pursuing CAR T cell therapy will be doing it through a clinical trial, a lot of the things that I'm going to talk about are related to that specifically and less on the treatment. But please feel free in the question and answers to ask me anything you'd like. I first learned about CAR T-cell therapy by paying attention to the trials that were happening in Europe. And I talked with my rheumatologist about them right away. And so then I was completely and totally prepared when I found out that there were trial sponsors recruiting at the Myositis Association conference to hit the ground running. And I spent literally 6 months of my life getting into this trial. It took me 6 months to get my screening scheduled. I went out, as you can see on the timeline, in early March. My screening trial and my cell retrieval actually were going to happen in the same trip. And so I found out at 7 a.m. the morning of the cell retrieval that I had been accepted into the trial. It was actually a delayed tuberculosis test, which was great to have to wait for that. But yes, so I found out I was in the trial. They took the cells. I went home, hung out for a little while, and then I returned to Denver. So as I mentioned, I'm in Minneapolis. My trial site's in Denver. There were no other sites that were closer. And so that was something that I had to deal with in picking out a site and figuring out what was going to work, not just for me, but for my caregivers, because as I'll get to, I had to have some people involved in the journey with me. We returned to Denver April 13th. I went through a series of tests to make sure I was healthy enough for the transplant, underwent 3 rounds of chemo, and then I had my CAR T-cell transplant, and it is like the most anticlimactic moment ever. It's literally 2 minutes, a vial right into your PICC line, that's it. The one side effect I had immediately was a incredibly bad stomach ache, not nausea, but like if you've ever had the wind knocked out of you or you get hit in the gut really hard. It lasted about 45 minutes. I was told it was completely normal, and then it was gone. As I mentioned, the process of it, the leukapheresis, which is the cell retrieval, the chemo, which is a chemo that I had already undergone as a dermatomyositis antisynthetase patient. In 2023, I actually went through 3 rounds of cyclophosphamide to try and manage my symptoms. So that was something I was used to and prepared for. And then obviously the CAR T-cell transplant. Life post-transplant. I've actually been in remission since November, which is incredible to share. Thank you. My strength is getting better. My fatigue is getting better. I've been off of all meds since before the transplant. The only 2 I continued were clobetasol and Opsilara for my mechanics hands. But if I could go back and do it again, here's what I would change. I would pursue more than one trial site at a time, because you will find out, even though they're recruiting, it's very hard to get somebody to call you back. I would also be upfront with them about that so that I'm not hurting any feelings, because I'm from the Midwest and we're very passive aggressive. I would get all of the reimbursement plans in written documents. I would have them all ahead of time. I would know exactly what I was expected to cover, because I've had some surprise bills. One of the things that has been incredibly frustrating on my end is I've had to pay out of pocket for everything and then go through the reimbursement process. And that has been incredibly tedious and has been something that's added a lot of stress to my life as I've been trying to recover. So you can obviously follow along with my journey. I share a lot of it on social media, but I'll happily answer any questions after the experts who can talk to you about the real important stuff of the trial. So thank you so much for having me today.
Thank you very much, Lindsay, for sharing your very open and transparent experience. Now we will have Professor Pedro Machado, who is a professor of rheumatology and neuromuscular diseases and a consultant rheumatologist at the University College of London, as well as the University College London Hospitals and Northwick Park Hospital, United Kingdom. His research focuses on the assessment, treatment, and prediction of outcomes in idiopathic inflammatory myopathies. In 2023, he was awarded the Michael Mason Award by the British Society for Rheumatology, or BSR, for excellence in clinical and scientific research. In 2024, he received the EULAR Honorary Award in Rheumatology for outstanding service in advancing the objectives of EULAR. Thank you very much, Pedro, for being here.
Thank you. Thank you for the kind introduction, and thank you all for being here today. And I'll give a kind of an introduction to CAR T-cell therapy. I'm sure some of you will have some knowledge about, some of you will have very little knowledge about it. So hopefully after this session, you'll be able to understand better what CAR T-cell therapy is all about. So these are my disclosures. I am a PI, or chief investigator, for several myositis clinical trials, and obviously I've worked with various companies in the field. So what is CAR T-cell therapy? Well, maybe before going to actually CAR T-cell therapy, maybe we should speak a little bit about immune cells. And there are essentially 2 types of immune responses in our body. One of them is the smart immune response, or adaptive immune response. where cells are able to recognize specific proteins, and they can target those proteins and therefore specific invaders, bacteria, viruses, parasites, and so on. And then there's a less smart immune branch, which is the innate immunity, where essentially they target everything that is considered to be foreign to your own body. Now, CAR T uses a smart cell, which are the T cells. And the T cells, they're kind of warriors in our immune system. And there are also various types of T cells. You have the cytotoxic T cells, and they produce toxic agents, and they go and they target and they kill infected cells, infected by viruses. They target the bacteria, and they can also kill tumor cells, for example, that should not be there. Then you have another group, which is the helper T cells, and they like kind of coordinate, they're the maestro coordinating the immune response. And then you've got the regulatory T cells, and they suppress the immune responses. So that at some point they see that the immune response, maybe this is starting to be too much, we could be harmful, and therefore they have the capacity to restrain the immune response. So now in the context of CAR T cell therapy, we're more interested in the cytotoxic T cells. An important thing about these T cells is that they have memory capacity. So they can remember the foreign proteins, the strange agents that have invaded your body in the past, and then if your body becomes invaded again, they can act in a much more faster, stronger, and specific way after re-exposure to those agents. So that's important in terms of the efficacy of using these cells. And the other important aspect is that they have a very good brain, they have memory. So they remember these foreign proteins, foreign agents for decades. So, and that could be potentially important. That is one of the reasons why a single infusion can potentially lead to long-standing clinical efficacy. So what is CAR T cell therapy? So it's a personalized treatment where we try to reprogram your own T cells and make them hunt and then destroy a specific target cell. Now, in oncology, that target cell is the tumor. In autoimmune diseases, the target cell that is most commonly used are the B cells. So you can make like a parallel between the tumor cells and these B cells, which are cells that are attacking your own body because they produce antibodies that are relevant and that are involved in the disease pathogenesis. So that's why the target is B cells, and these autoreactive B cells, they can be compared to the tumor cells, and that's why the CAR T cell therapy is also used in oncology. So what do? We extract the cells, the T cells from the person's body, and when we modify it, and what we modify is this T cell receptor. So that's like the antenna that the T cells have that tells them which cell to target, in this case, the B cells. But in order for the T cells to target that specific cell, we need to modify them, and we modify them in the lab. And after modify them, we give them back to the patient, modified, and then those T cells will go and chase the bad cells in your body that are perpetuating the disease. So that's the rationale. And these are all the antibodies that have been described as associated with the various types of myositis. We know that many of these are important in disease pathogenesis and in the way the disease manifests itself, something we call with disease phenotype. And this is why target B cells make sense in some types of myositis, not all of them, but I'm sure we'll discuss about that as well. Now, this is not new. B cells have been targeted for quite a long time, namely with rituximab. The difference is, so rituximab is a monoclonal antibody targeting CD20, which is a molecule that is at the surface of B cells. So if you target CD20, we're essentially targeting B cells. But not all B cells have that CD20 molecule. You can think about the life course. So you'll have baby B cells, and you have very elderly B cells, and across that life course of B cells, and they can live in many places in your body. They can be in different organs. They can be in the bone marrow. They can be in your spleen, your lymph nodes, your bloodstream. So depending on how old they are, they will also be in different places. Now, the problem with the CD20, it's not expressed in all types of B cells. So what we think is rituximab, so essentially not targeting all types of B cells, and probably is not reaching some of the organs and tissues where some of these cells are hiding. So people thought, okay, let's find a better way to find those B cells and kill those B cells, right? And that's what we're doing with CAR T-cell therapy. There are other ways, for example, like an intermediate way between this monoclonal antibody approach and the cell therapy approach is this bispecific T engagers, so-called BiTEs. And essentially what they do in a very simple way, they have receptors for both the T cells and the B cells. They make them come together, therefore an engager, and then they promote that. So it's a death engagement, essentially. So there are various ways of doing that. We think that by using CAR T-cell therapy and using a different marker, which is usually CD19, but there are many other markers being explored, okay? But I think that's for another talk. The main one is still CD19, but there are others. By doing that and targeting a different marker, we hope to achieve a better depletion of the entire range of B cells. So what are the steps in manufacturing these modified T cells? So the first step is actually collecting the cells from the person. That's called the apheresis process or leukapheresis. And I'll go through these steps in subsequent slides. The next step is after extracting those cells, they need to be modified. The lymphocytes are isolated, and those cells need to be activated, and then they need to be transferred. We need to put something inside the cells that makes them produce this T cell receptor, that antenna that is then going to make them able to target the B cells. Then they need to be expanded and concentrated in a small bag, and then over a 1 or 2 minute period, we give the cells to the patient. Now, this is an evolving field, and these are the types of things that you may hear about in the future. So in terms of type of procedure, the procedure that I just mentioned is called an autologous procedure because we're using the patient's own T cells, right? We extract them, we modify them, and we give them back to the patient. There are now other ways of manufacturing T cells being developed. One of them is allogeneic T cell approach, whereby we use cells from donors. There are some potential additional risks with that, namely the risk of immunogenicity, so creating an immune reaction of in the body against something that is external, essentially. And there's now also other approaches being developed that include in vivo modification of the cells by injecting something, for example, in the bloodstream that will then target your T cells and then will modify them in vivo. Okay, I think these are all at the earliest stage, but it's something that you might hear about in the future. The other thing is typically the way we modify the cells in the lab is by using a virus that has some genetic material inside of it, and then that virus goes into the cells, the genetic material goes into the cells, and then it produces that antenna that will make the cells target the B cells. And that's usually done, so it's a viral vector. But there are now other ways of doing that, including lipid nanoparticles, again, something that you might hear in the future. And then the other thing is that we're not only looking at T cells, but also other cells that can potentially do the same type of job, namely NK cells and gamma delta T cells. Okay, so this is just a glimpse of the future. Let's focus now on T cells and autologous T cell approach, which is the most used one. So next slide is about the patient journey. So the first step is checking if someone is eligible or not for a specific CAR T cell therapy trial. And this is not a trivial step, because usually each trial has probably 70 or 80 inclusion and exclusion criteria. And there are many things that can make you ineligible for a clinical trial. Then the extraction of the cells, that's the apheresis process. You might need some therapy changes after the apheresis and while you wait for the other steps of CAR T cell therapy. So that's something to bear in mind, and depending on the protocol, what you're allowed to do during that period might be different. Then the cells usually go somewhere to be manufactured. That process can take quite a long time, depending where the cells goes. If it's an in-house product, it can be as quick as 2 to 3 weeks. But if it's not an in-house product and then the cells need to go to another country, it can take up to 3 months in some cases. So it can be a quite long waiting period. And before the infusion of the cells, there is that chemotherapy step that has already been mentioned. Usually it's with a drug that is also used in myositis, cyclophosphamide, often coupled with another drug called fludarabine. It's, let's call it a light, mild chemotherapy. And then after the infusion, obviously, there's a lot to say in terms of the monitoring on the short term, but also on the long term. So I'll now speak a little bit more about each one of these steps. So eligibility, so that's essentially the step where you go to the hospital, your disease is reviewed in detail, your medical history, your treatment history, your physical function, and so on, and that is compared with the trial eligibility, inclusion, and exclusion criteria. And in order to be accepted in that specific clinical trial, you need to fulfill that criteria, those criteria. It's not trivial, and you'll probably hear about patients that have been very frustrated because they do not fulfill the criteria. I'll give you 2 examples of my own patients. So this is a lady, she's 55 years old. She has a diagnosis of PL12 positive antisynthetase syndrome with significant multi-organ system involvement. So she has skeletal muscle disease, so weakness, but she also has cardiac, myocarditis, lung, interstitial lung disease, and joint involvement, so arthritis. And this lady has failed multiple therapies, including prednisolone, methotrexate, IVIG, rituximab, and cyclophosphamide. And therefore, I felt that she was a strong candidate for CAR T cell therapy, and she was also very keen on getting this type of therapy. At screening, that was her CK, 6,600, which is significantly elevated. And that's her muscle strength scoring. She had a score of 125, and the maximum score is 150. So she had significant weakness. Now, this lady fulfilled all the criteria except one, okay? She fulfilled 60 criteria, but there was one that she did not fulfill, and it was the lung function tests. So she had, like I said, she had lung disease, interstitial lung disease, and there's one test called forced vital capacity, and she had a value of 45%, and that was below the allowed threshold, which was 60%. So because of that, I could not give her CAR T cell therapy, which was a source of big frustration for both of us, actually. And I tried giving it in a compassionate use modality, but the company didn't have a program, so I could, we had to find an alternative way of treating her. So this lady, let's say, was too unwell to fulfill the eligibility criteria. But there's actually also the opposite spectrum, because you might be too strong to meet the eligibility criteria. And that's the next example that I'm going to show you. Again, one of my patients. This is a young lady, 32 years old, and this lady has immune-mediated necrotizing myopathy. Not the same antibody as Karen and Guillaume, another one. It's the anti-HMGCR, anti-hydroxymethylglutarate coenzyme A reductase antibody. And she only has skeletal muscle involvement. So she doesn't have other organs affected, only the muscles. And she also did not respond to multiple therapies. She's a singer and a dancer, and she would really like to go back to her normal life, be on the stage again, which she still cannot do. Her CK was 4,000 at screening, active disease, but her MMT was 140 out of 150, and that's too high to be eligible for this clinical trial. So I could not give it to her because she was too strong. Okay, let's speak a little bit now about the other steps. So the apheresis is that process whereby we remove the white blood cells from the blood. Essentially, we connect the patient to a machine. You can, it's a bit like the dialysis machine. It can be either on using a peripheral vein or a central vein, but usually a peripheral vein is adequate. And then your blood is kind of filtered there, and we extract some of the white blood cells. This is a long process, takes maybe around 4 hours, because obviously we need to filter a large volume of blood, and that's something that cannot be done in a very quick way, otherwise the patient would feel unwell. After this is done, we send the cells to the manufacturing facility, but while the patients wait, we might need to modify therapies. Depending on the protocol, what we are allowed to do will vary. So that's something to take into account as well if you think about entering a clinical CAR T-cell therapy clinical trial. There might be a maximum limit in terms of steroid dosages, for example. So and also ask about the manufacturing time, because then this bridging period might be shorter or quite long, up to 2 or 3 months. And before lymphodepletion, there might be the need, for example, for a washout period, so a period where your drugs actually need to be lowered, for example, the steroid dose. So that's also something to take into account. Washout periods, again, vary depending on the clinical trial. May only be a few days out of steroids, for example, or up to a certain maximum dose of steroids, but it will depend on the clinical trial. And obviously, if you're lowering the dose of your medications, that could trigger a flare. So again, something to take into account when thinking about participating in a CAR T-cell therapy clinical trial. Then the lymphodepletion chemotherapy step. This is typically done in an inpatient setting, just before or a few days before the CAR T-cell therapy infusion. And as I mentioned before, the most commonly used drugs are fludarabine and cyclophosphamide. The doses that we use are lower compared to the doses that are used in oncology, for example, but there can still be some side effects associated with that, namely nausea, fatigue, swelling of your legs, for example. Your blood cell count can go down a little bit. Usually there's no air loss, although there could be some air thinning. And finally, the infusion, which I agree it's a very anti-climax process. You've got a bag there that is infused over just a few minutes, and then you're done. Now, what happens afterwards is really important, because patients do need to be carefully monitored. Usually the first 2 weeks, it's done as an inpatient, close observation in case there are immediate side effects. After that, usually patients need to stay close to the hospital. Again, it depends on the protocol that you're using, but 2 to 4 weeks at least. Some companies will pay a hotel so that you can stay close to the hospital with a relative. But this period of monitoring is also important to take into account. And, is there a carer available? Is there a family that can go with you, and so on? This has important practical implications. And just a quick overview of the potential side effects. There's some immediate side effects that can occur, like cytokine release syndrome, these immune effector cell-associated immune effects. Essentially, what they mean is that your immune system can start overreacting, and that can lead to changes in your blood cell count, for example. You can start having fever, like you have an infection, very fatigued. It's essentially like an hyperactivated immune system, and then you can also have neurological consequences of that. So in the first few weeks, patients need to be really carefully monitored to see if any of these side effects develop. There can be some more long-term side effects, such as low cell counts, and more recently, it has been described the possibility of secondary malignancies, T-cell malignancies. It's rare, but it has been described in the oncology field. To my knowledge, it has not been described in autoimmune diseases, but obviously we'll only be giving these therapies to patients with autoimmune diseases quite recently. This is something that has been described more recently. It's called LICATS, local immune effector cell-associated toxicity. And essentially, it's again an hyper-inflammatory state that can mimic a disease flare. And there could be the tendency, if diagnosed as a disease flare, there could be a tendency to over-treat with too much immunotherapy, immunosuppression. But however, this is usually transient. And there are two options. Either you watch and wait, or you can give a little bit immunosuppression, so like, for example, a bit of steroids over a short period of time, and then it usually tends to go away by itself. And finally, this is almost my last slide, the collaboration between the rheumatologist or the neurologist and the oncologist team is critical. This can only be done if there is a close collaboration between the cell therapies team and the rheumatologists/neurologists. They have the skills and the knowledge to give these therapies. We have the skills and the knowledge about the conditions, and best care must involve both teams. And that's why I'd like to finish with a big thank you to my cell therapy team. They've been extremely supportive through this journey since the first cases of CAR T-cell treatment in autoimmune diseases was described. I always do the screening visits and the consent with my colleague Claire Rody. We're there together, speaking with the patient, because that way we can be sure that we're able to answer all the questions, both about the specific treatment as well as about the condition. Thank you.
Thank you very much, Pedro, for this very nice presentation. And now I would like to welcome on stage Dr. Rebecca Nicolai, who is a pediatric rheumatologist working as a clinical researcher at the Division of Rheumatology of the Children's Hospital of Rome in Italy. Rebecca has a strong interest in juvenile systemic connective tissue diseases with a focus on juvenile idiopathic inflammatory myopathies. Rebecca is also the lead of the clinical care and clinical science pillar of the Pediatric Rheumatology European Society JDM Working Party. Rebecca, the floor is yours.
thank you, Guillaume, for your introduction, and thank you all for being here. It's really a great pleasure to be part of this workshop. And after hearing Lindsay's journey and now Pedro's great presentation on the more general aspects of CAR T cells, we are now going to focus on the potential application of CAR T cell therapy for juvenile idiopathic inflammatory myopathies. I have no disclosures. To start, I would like to bring to your attention some general aspects on considerations on pediatric onset autoimmune diseases. Children with autoimmune diseases tend to have more severe phenotypes and often also higher mortality rates when compared to adult autoimmune disease patients. They have a higher progressive accrual of organ damage. This is both related to the drug toxicities and to the disease, and also obviously is dependent on the early onset of the disease and the potentially long life course. Treatment for autoimmune diseases impact on growth, metabolism, bone metabolism, and fertility, and there are also important considerations on poorer academic growth and social development to take into account. So these are a lot of aspects to consider when speaking about children. As you probably all know, idiopathic inflammatory myopathies are a very heterogeneous disease group. Juvenile dermatomyositis is the most common juvenile subtype, accounting for more than 80%. But it's still a very rare disease. You can see the incidence is of 2 to 4 new cases per million children per year. So it's a very rare disease. And there are currently no approved drugs specifically for JDM, so it's an orphan disease. There are a lot of unmet needs for JDM patients. Vasculopathic complications such as deep skin ulcers or intestinal vasculitis, which can lead to intestinal bleeding or perforation, and also calcinosis are more commonly described in children with dermatomyositis compared to adult patients, whereas interstitial lung disease and association with malignancies is more common in adults. Long-term damage has been reported in up to 70% of patients with JDM. And again, this is both related to the ongoing persistent disease activity and to the drug toxicities. And only about 50%, so half of the patients with JDM achieve a drug-free remission. This means that the other half of the patients has recurrent or chronically active disease. This leads to a high burden of mental health disorders as well. The pathogenesis of JDM is complex and not completely understood, but certainly B cells, which you see here, are an important part of this complex puzzle. And this is the reason for B-cell targeting therapies having been attempted as a treatment for inflammatory myopathies over the time. And in this figure, you can see that the treatments circled in red are the ones for which have been also attempted for juvenile myositis. And you can see also that there are CAR T cells in here, and that's because the CAR T cells that we are currently using for the treatment of autoimmune diseases are CAR T cells that mainly target proteins present on the surface of B cells, such as CD19 or BCMA, as Pedro already told us. And so currently, we are using them essentially as B-cell depleting therapy. But from the very beginning, from the very start, when we started to use them for autoimmune diseases, they appeared a real breakthrough, able to induce prolonged periods of drug-free remission without the need of glucocorticoids and immunosuppressive treatments. And the first SLE patients, which has been treated in Germany in 2021, has now completed 5 years of drug-free remission in follow-up after receiving her treatment. Currently, there are around 40 trials enrolling patients with myositis for CAR T-cell therapies, but only 6 of those trials enroll also juvenile patients. So there is a lot more options for adult patients than for juvenile myositis patients. These are the first 2 JDM cases which have received anti-CD19 CAR T-cell therapy. The first one has been treated in our hospital. The second one was reported by a Spanish group in Madrid. But more recently, our center, in collaboration with the German group in Erlangen, published this mixed case series of 8 pediatric patients with treatment-refractory autoimmune diseases. And this case series included also 3 patients with JDM, which were all treated in our center. And these 3 patients include also the first patients, which has been also reported with a short-term follow-up in 2024. All 3 patients received their CAR T-cell therapy between June 2023 and December 2024. So the longest follow-up is almost 3 years for the first patient, and as part of a hospital exemption program. So this was not a trial. The CAR T cells were produced on site, so we are lucky we have a cell factory, and so the manufacturing process took only 14 days, so 2 weeks, from leukapheresis to reinfusion to the patient. And for the manufacturing process, a lentiviral vector has been used. All patients received a standard dosing of 1 million CAR T cells per kilogram of body weight after undergoing the lymphodepleting chemotherapy we already have heard about. And this is the machinery, the device used for the production of the CAR T cells. In this table, you can see the main patient characteristics. All 3 patients had persistent severe muscle and skin disease. All of them had calcinosis, ulcerations, and the last patient, the 3rd patient, also interstitial lung disease. And before undergoing CAR T-cell therapy, all of them had received at least 5 standard immunosuppressive treatment lines. After the CAR T-cell infusion, the CAR T-cells expanded in the blood of the patients and reached a peak at around 7 days after the infusion, and then quite rapidly disappeared from blood. So you can see that between week 6 and week 8, they completely disappear from blood. And this is the same time frame when the CD9 positive B cells, which completely were depleted from the blood after the CAR T-cell infusion, started to reappear in peripheral blood. To assess the clinical response to the treatment, we used the total improvement score. This is a score, a composite score, which has been developed to assess response to treatment and is often used in clinical trials. It measures both patient and physician reported outcomes. And in this slide, you can see the adult core set criteria and thresholds for minimal, moderate, and major response. But it's important to keep in mind that in pediatric patients, the core set measures are quite different, and also the thresholds. So using this total improvement score, 2 patients achieved a major clinical response and 1 patient a moderate clinical response already 6 months after the CAR T-cell treatment. And in this figure, you can see how rapidly the global disease activity assessed by both the patient, parent, and the physician decreased over time after the treatment. And also in this figure, the rapid improvement of the skin disease activity scores. We used the skin DAS score and the cutaneous activity tool for dermatomyositis, which is the CAT score. But I think that more than these graphs speak the pictures of the first patient treated in our center. This is the boy reported in 2024. He presented a complete resolution of his skin rashes, subcutaneous edema, calcinosis, ulceration, and also he had some alopecia. You can see this in the first pictures, and look at the curls here in the last one. So this patient also presented significant abnormalities of the nail fold capillaroscopy at baseline, and these changes completely normalized after 24 months of follow-up. But already at 6 months, you can see that there is really an impressive improvement of the nail fold capillaroscopy in patient 2 and also in patient 3. When looking at muscle strength and muscle function, the recovery was more slow in all patients. Patient 1 achieved a normal muscle strength assessed with this CMAS, which is the Childhood Myositis Assessment Score, at 9 months, and then maintained a normal CMAS, but the other 2 patients still presented abnormal CMAS scores at their last follow-up. Nevertheless, when looking at the MRI scans, you can see that these whitish areas which show the inflammatory muscle involvement are significantly reduced at 6 months in the first patient, and then completely normalized at 18 months. And also there was a complete normalization of these subcutaneous changes, which are not present anymore at 18 months. And the same for patient 2, here the yellow arrows indicating the inflammatory changes, which are no more present at 6 months. And again, in patient 3, here the muscle inflammation, which is significantly improved or resolved at 6 months. The one patient with interstitial lung disease underwent a CT scan 6 months after the infusion, and you can see that there is a significant improvement also of the interstitial lung involvement and bronchial wall thickening in these pictures. So this is these are areas of interstitial lung involvement and bronchial wall thickening. But let's speak also about safety, which is very important for such an innovative treatment. 2 out of 3 of these patients presented a grade 1 cytokine release syndrome. This means fever substantially. 1 patient presented a grade 1 ICANS, which was characterized by confusion and transient electroencephalographic abnormalities resolving spontaneously after 72 hours. In all patients, we recorded anemia and neutropenia, which were limited to the first weeks after the infusion. No patient required IVIG replacement, and infections were limited to upper respiratory tract infections. So overall, in this small cohort of patients with JDM treated with anti-CD19 CAR T cells, the treatment appeared to be feasible, efficacious, and also safe. But there are a lot of points to consider for future research. Obviously, the efficacy needs to be confirmed through trials with long-term follow-up. We also need to address the issue of the response criteria and to assess the durability of drug-free remission when this drug-free remission is achieved. It is very important to continue the monitoring of toxicities, both the early ones and the long-term toxicities, which Pedro already told us about. And also there is a lot of work ongoing for the definition of selection criteria for the patients. And I believe that a better understanding of the B-cell resetting, so to understand what happens to the B-cells when they reappear and what happens to B-cells and other cells during flares after CAR T cells, because this has already been reported, will give us important insights into the pathogenesis of the diseases we are treating. And I also want to thank both teams involved in our CAR T cell program, but also the rest of my division, but most of all patients and families, CureJM for support, and obviously you for listening. Thank you.
Thank you very much, Rebecca. It was also really nice to see the positive results that you've achieved. The floor is now open for questions. There is a mic in the middle aisle if anyone has questions.
What do I have to do with this? Just come up, or do I have to touch it? No, just speak. Hi, really for Pedro, because he's the one I know best. You mentioned compassionate grounds for trials. What kind of companies, or do people actually do it, or is it just a nice idea? Are trials ever offered on compassionate grounds, in your experience?
There are, yeah. No, it is done, but there needs to be a program by that specific company. And in this case, unfortunately, the pharmaceutical company did not have a compassionate program. But sometimes they do have it, and in that scenario, we are allowed to give it under compassionate use. Hopefully, in the near future, there will be more companies doing it.
Yeah.
Hello, thank you so much for that lovely presentation. I'm Shannon O'Connor. I'm coming from Cincinnati Children's. I'm a pediatric rheumatologist. And I was wondering from the patient perspective if you could project your experience and wisdom onto your childhood. Is there something you wish we could tell kids before they go through this process as we embark on our first CAR T trials for JDM?
Are you asking specifically for kids?
Yeah.
Okay. One of the things that I think is a really important conversation to have, especially with young girls and young women, is the potential side effects for fertility. I had undergone cyclophosphamide in 2023, and I was given a 2-hour window to decide whether I wanted to be hospitalized and try and get better or save my fertility. I now know that the process of going through that, and again, all the medications that you take as a myositis patient, they're not friendly to the reproductive organ. So I would say, honestly, that's a big one. I would say also, I've heard from a lot of patients that their providers are telling them like, oh, it's a really intense process and it's really aggressive on the body. And yes, it is. But I think sometimes the providers forget what we go through, not just with dealing with the symptoms of our disease, but the medications we're already on have incredibly serious side effects that are intense. And so I think for a lot of people, it's like, okay, I'm gonna go through this really intense 6 to 8 weeks, right? But, I mean, the outcomes are worth it, in my opinion.
I appreciate that. Thank you so much.
In terms of the fertility issue, something that we do as a standard is all women of childbearing age, they go to our fertility clinic to be advised and given the various options in terms of fertility preservation. So that's something we do to all our female patients of childbearing age, and something that I would recommend that all places do.
I just wanted to add, thank you very much for that question. From a patient perspective as well, I'm one of these patients who is quite afraid of lymphodepletion. So if there was a trial that I would sign up for, first of all, having an anti-SRP positive IMNM, I believe that I would need a BCMA targeted CAR if possible. And I would also love to not have to go through lymphodepletion, just purely because I'm chicken about it. Although I know that Lindsay had a very pleasant-ish experience, but we are all very different and all of us react differently to different things.
I think it also depends a lot on previous drug experiences. One of my patients had 6 cycles of cyclophosphamide. So she did not have any concerns about that specific part of the treatment. Yeah, but obviously it all depends on your personal experience, previous treatments, and so on.
Yeah, also 2 out of 3 patients in our experience had already had been treated with cyclophosphamide, so it was nothing new for them. And really the idea of getting off therapy, so being without immunosuppression and without glucocorticoids, was the most important thing for both the patients and the parents. So this sort of future option was really the most important thing for their decision to undergo the treatment.
I think it's also the stage of your disease journey that you are on. If you had asked me the same question 20 years ago when I was diagnosed and completely incapacitated, bedridden, I probably would have said, go ahead, shoot me up with the lymphodepletion. So it really depends at the stage of the journey. Linda, you had a question.
Forgive me if you've already mentioned this, but I'm curious about whether any of the children had calcinosis and what the impact of the treatment was on that.
Yes, all of them had calcinosis, and the first two really extensive, and I would say calcinosis universalis, because the first two patients really had impressive accumulations, and the follow-up is too short for the second one, but the first patient, which is now almost, as I said, 3 years into treatment, has completely resolved calcinosis all over the body, yeah.
Hi, my name is Ingrid de Groot. I'm the chair of the Dutch myositis group. Thank you, first of all, for a very insightful session on a therapy that's been really promising, but very complicated material for most patients. And you did it really well with the lay language, so thank you for that. I have, if there's nobody behind me, I have 2 questions actually. And 2 things resonated with me in Pedro's speech, and that was the 2 patients that were not meeting the inclusion criteria. First of all, my question is, the lady with the ILD, she didn't meet the 60% lung function lung capacity. She had ILD. I know I'm one of them. I'm a patient with diaphragmatic weakness, so I would not, I would be borderline if I would meet it. Would be different if she had the bad lung function because of diaphragm weakness, or is it like a hard cutoff? And why is it like 60%?
Very good question. So regarding the cause of a lung disease, it was mainly due to interstitial lung disease, not a diaphragmatic issue, but an issue with the lungs itself and the exchange of oxygen in the alveoli. So that was the main reason. But there was also, interestingly, a component of fatigue, I think, that was contributing to the very low result in the lung function test. So we were given the option of repeating the test, which you can do only once. And I even tried to do some coaching on how she might be able to do a little bit better. So we tried. It didn't work, unfortunately. Okay. Now, the threshold, it's completely arbitrary. Why is it 60%? I don't know. No. Because the company decided that it was 60%. It's completely arbitrary.
Okay. Well,
I think that some of these thresholds simply, they have been translated from the hematologic experience to autoimmune diseases. Again, also cardiac function tests. I think those are some standard values that they are using for assess a sort of general fitness to undergo this kind of treatment.
And for me, with the qualification, I was very certain that last day that I was not going to qualify because of the MMT8 test, because I was very strong, so to speak. You know, for me, I was very weak because it was at my weakest. But the MMT8 test showed that I had some
That's my
strength.
second question.
Yes, we've talked about this.
Yeah.
But I couldn't roll over on the table to continue the test. 2 grown men had to flip me over. And I'm fairly certain the rheumatologist had a conversation about this criteria is arbitrary. And we have a patient who we can see if she's going to be doing better. So.
Yeah. And thank you for that, Pedro, because we come to the MMT later, but you coached your patient to do the second time to do it better. And I appreciate that. But I always ask for the children's lung function test, no kidding, because they have to blow out candles or fly away bowling balls, etc. And I do better. And I'm not ashamed, so I always ask, put on the the kids program. So that's another thing. And I think the second time, was there time between it, or did she have to do it within the hour? The second, or
one week apart.
Oh, okay. So, okay, fair enough. So the MMT8, that's the other question, because you said the lady was quite strong. And yeah, well, Lindsay also addressed we talked about it earlier, but you said she was also a professional dancer. And I can imagine that to her, life is nothing without her dancing. And it's so harsh to hear that a woman who scores high on a very among patients discutable. Well, we have discussions about the MMT. And she scores high, and she would have scored high because she's strong, but apparently with the dancing you need more endurance, and that's where the problem is with most myositis patients. So that's another thing I did. It's not a criticism, but I think that needs to change. Like things like we take over thresholds from the cancer research. Myositis is a different disease altogether, so we shouldn't do it. We should look into that, and also the MMT, because it's not about strength per se, but it's also about endurance. That was just the two remarks I wanted to.
The only thing I can say is that you read my message perfectly.
Yeah, okay.
And I fully agree. You know, she's strong in some sense, but she's not strong enough to have the life that she wants.
No.
Okay? She's not able to perform, to sing, and to dance as she used to. And that's what she needs. And it's very unfair, I think.
Yeah.
It's very unfair.
We had a holistic session, and it's about quality of life and treating the whole person. So to her, that would
it's another arbitrary kind of.
Yeah. Okay, well, thank you for that.
But on the same subject, what influence do you got people like
Could you just
two?
repeat your question?
What
'cause we're
influence?
recording.
Sorry. What influence do people like you two have on the drug companies to say to them, "This is ridiculous"?
So we can have an influence, and we kind of doing that, myself and other colleagues in the field, and also with the help of patients. We're trying to modify that. We're involved in a few global initiatives where we're discussing with regulatory agencies and pharmaceutical companies, highlighting the issues with clinical trial design in myositis. So we are trying to do something about it, and hopefully we will be able to influence the way these trials are designed in the future.
Yeah. So everybody has that say. So the people in the pharmaceutical companies who are coming up with that, they have a vested interest to make their drug work. So I would have thought they'd love people like you two coming along and saying, this is not meaningful, it should be 40%, this one should be 70%, this criteria number 56 should be 3, not 7.
Yeah, but they're also risk adverse.
They're risk averse.
Yeah, and
then the drug trial fails.
Yeah, and I think that's one of the reasons, you know, if someone is quite unwell, I think they're probably afraid that that's going to lead to a poor outcome, for example, because their baseline status is already quite debilitating, or if someone is maybe a bit too strong, maybe the efficacy that they will be able to show will not be as big. So there's various factors to take into account. Some of it is historical, something that has been a lot in the past, and then they're afraid of changing it, and how it will be perceived by regulatory companies if they
and that's
change
what
a lot.
you guys can help with, yeah.
If I can just add to that, one of the things that a mentor of mine walked me through during the process of screening was, one, keeping in mind that this isn't a drug, it's a treatment. And so it's not the traditional sense of a clinical trial. But also, for a rare disease group, you're talking, I mean, I think in the paper I'm in, I'm like 1 of 11 patients, so it's such a small group. And what my mentor was telling me was like, keep in mind, they're looking for very specific things so that not necessarily they can prove that it works, but that especially for phase 1 trials, that there's not somebody who skews the results so far one way that they don't have the right data that they need to move forward.
Yeah, that's a good one. I think the best thing you just said was that, remember, it's a treatment, not a drug. And I'm trying to educate myself in that. There was a very special period, which Pedro knows about, in the 80s, with the onslaught of HIV. One of the things that the patients took on was saying, I want to take it, give it to me. And they died. But they left a legacy of research that are now the next patient's not to die and the next one's not to die. So the aggression of the patients drove the regression of the patients, but that was, you've just helped me with that. That was a medicine, a drug, a pill, as opposed to a treatment, which is fundamentally different. So that was, but the passion of the patients and the doctors together telling the drug companies to just butt out and get on with it was very much about the 80s.
Thank you very much. I think we've all heard our voices loud and clear today. So for those of you in the room from the industry, I hope this resonates with you for a positive change in future trials. So I just wanted to close the session. Unfortunately, we do have run out of time now. But please do continue these conversations outside and for the rest of the Gcom and beyond the Gcom. Thank you very much to our clinical speakers for supporting our session and all the questions that came from patients. And also thank you to Lindsay. And thank you, Guillaume, for being the co-chair of today's session. So we hope you enjoyed it all.
But, well, it's a continent to you. It's what I said to Pedro. Always,